To the neurosurgical case room. Am I audible?
Walaikum salam, yes.
Okay. Thank you so much for joining today. I'm very sorry for having missed sessions in between. This week was weeking sort of. So we are going to cover the surgical indications today, and after the surgical indications, we will look at the parasagittal approach, which is also the anterior interhemispheric approach. Sort of a lot of the steps are similar. So we are going to cover those. There are two things that I really wanted to cover today, but I could not fit them in due to time. So let's see. I will probably leave a PDF handout at the end of the session on the WhatsApp group. So without further ado, let's begin. We are going to discuss the surgical indications of parasagittal meningioma. And obviously the first indication is going to be on the size. If it is less than 3, if it goes for SRS, we know that. If it is more than 3 centimeters, causing significant problem, then it goes to this microsurgical pathway. Apart from that, symptoms are also important. Location is going to factor in heavily as well. Along with the location, we want to see the extent of collateral circulation. Why? Because we are concerned with the status of the superior sagittal sinus, how much of this is involved, and the greater the involvement, the more robust the collateral circulation is going to be. If the superior sagittal sinus is heavily involved, the collaterals are going to be really, really well developed. And what do? Collaterals are like insurance policy. If you have robust collateral circulation, there are lesser chances of patient having a severe post-operative hemorrhagic infarct, especially in the venous territory that was involved. So collaterals are your insurance policy. There are cases in which there is a recurrence of this parasagittal meningioma, and the surgeons they deliberately wait instead of proceeding directly to a surgery. They would wait for the sinus to be completely occluded. Once it is completely occluded, the collateral circulation is going to be a lot more stronger. And if that is stronger, I'm using the CC, which means collateral circulation is going to be a lot stronger. And if that is a lot stronger, then you can take a chance and resect all the involved portion of the superior sagittal sinus. It's not a wise thing to do if superior sagittal sinus is not completely involved. You risk the patient, especially if it is the middle third. We have already discussed that. But if this is recurrence and there is a strong collaterals on the DSA or on the MRV and the superior sagittal sinus is completely occluded, then you can even proceed for resection or sometimes, complete excision and then repair with the graft. Along with that, edema is really important. Meningiomas we know that they are extra-axial lesions. Extensive edema usually shows two things. I believe we have discussed it before, but let's still discuss it again. If there is extensive edema, there is one of these two scenarios or sometimes components of both. There can be bile parasitization. If there is extensive edema, especially disproportional to the size of the lesion. The other thing is there is venous congestion. So the venous outflow of the brain is blocked or involved to such a degree that now it is causing congestion. The congestion is ultimately leading to this edema. So if we need to figure out which particular scenario this is, whether the pia is involved or whether there is extensive venous congestion. Why? Because once we open this patient, if the brain is really edematous, it's going to give us a very tough time. It's going to be an angry brain, and angry brains do not result in good surgical outcomes. I'm sure most of you would have experienced it at least once during your residency. So bile parasitization also hinders our surgical resection, because we know for meningiomas, I have repetitively emphasized on one thing, that is preserving the arachnoid plane. So if your arachnoid plane is not preserved, then if it is either on the surgeon's part or if it is on the lesion's part, whichever way, if the arachnoid is not preserved, then the surgery is going to go slightly difficult, because arachnoid is your natural map. It's your natural GPS inside the brain for extraaxial tumors. What pile parasitization does is, you will not find a very good plane. And then you will have to use the bipolar cautery. You will have to create an artificial plane in order to do a complete resection. Am I clear?
Yes.
Okay, moving on. So we just discussed this because the lesion is a chronic lesion. There will be good collaterals, and they're necessary for adequate venous drainage. Apart from that, there are multiple studies on this as well for surgeons who still like to do a GTR in parasagittal meningiomas, opening up the sinus, taking all the tumor that is inside the sinusoidal portion. Even if they take it out and they reconstruct it, the recurrence rate is higher. And this is not just for tumors which are involving the sinus. The recurrence rate is higher in all parasagittal meningiomas in comparison with the other locations. I believe we discussed this in first session as well. There are two other things. This location particularly has a higher risk of having a grade 2 or grade 3 meningioma. So that is also a higher risk. Apart from that, recurrence risk is also higher. So even if you are doing, you are doing the painstaking job of taking the tumor inside the sinus out and reconstructing it with the graft, you still are going to have a higher rate of recurrence. Please give me a minute, just a minute. I'm sorry for the interruption. So let's get back. The sinusoidal portion of lesion should only be resected if it shows complete occlusion. Also, even if it is showing complete occlusion on the preoperative imaging, there will be cases in which you will find that the sinus was not completely occluded perioperatively. And in those cases, it will still be a good idea to leave some intrasinusoidal lesion and send that patient for SRS instead of attempting a complete resection. But there are two schools of thought here. There are surgeons who are inherently more aggressive in terms of their extensive resection, and there are surgeons who would prefer to, go slightly more conservative. And so it would vary from center to center and from surgeon to surgeon. The other option, in fact, there are two options. We discussed one. We discussed the extensive edema due to venous congestion, venous hypertension. If that is the scenario, a stent can be considered. If you have ruled out that the raised ICP is due to the lesion, for example, you have this lesion with a relatively small size. The size is not big enough to cause extensively raised ICP, but there's really huge amount of perivaginal edema. It could be suggestive of the parasitization or the venous hypertension. If you have ruled out the pile involvement and you think that this could be venous hypertension, then stenting is an option. Apart from that, invasive supraselective angioembolization is also an option, but again, the results vary from center to center. And why is that? That is because a lot of the deeper feeders in the parasagittal meningioma, as we will see, because this is so close to the fox, there will be two very important vessels which can lead some feeders here. For example, you can have the pericallosal arteries here. You can also have some branches from the callosal marginal arteries because they are in very close proximity. So they can lend feeders to the tumor, and angioembolization can have variable results. Moving on to the surgical principles and the steps, we are going to look at the images first and do a pictorial journey. At the end, we will go step by step in the text so that, it's easier to understand and the retention would be better. We all know that once we are opening the sinus, the safer approach will be to straddle the sinus with the burr holes. Can somebody unmute themselves and let me know what is the particular approach they use? Is it this two-burr technique, or is this one-burr technique that I have in the next image?
Madam, we use two burr hole technique.
Okay, where are you from? You are from KP, I believe.
KPS.
Yes. So yes, what I have practiced and what I have seen my seniors do is this two-burr hole technique, because this is safer. This would work if you have a craniotomy or an oscillating saw. This could work. I personally have always liked this one. It gives the sense of safety. So we have these burr holes, a set of burr holes, which is going to straddle the superior sagittal sinus. And one goes on this side, one goes on this side, and this, and then you raise this flap. And after you raise this bone flap, you will gently elevate this dura. You will create an epidural space between these burr holes very gently, so that you do not end up piercing the sinus wall. And even with this, if the meningioma is big, there is going to be bleeding, because the dura is very, very vascular in meningioma cases. Apart from the craniotomy, the incisions are also variable, and they would depend on where the lesion is. For example, if it is an anterior third lesion, you have the option to go modified unicornal. You have the option to go bicornal. Considering that this is the same case, I'm just using the other scalp. So you have these options. Let me clear this. When we come to the middle third, for the middle third and the posterior third, the trapdoor incision is a very good idea, because it provides a wide base and you can cross the suture, you can go to the other side, because for parasagittal meningiomas, let me write here, for parasagittal meningiomas, you need to have the contralateral side of the superior sagittal sinus exposed. Apart from that, if the tumor is crossing the midline, you would want 2 to 3 centimeters of opposite hemisphere exposed as well. But that would depend on your case. If your lesion, if that particular case, the lesion is not crossing the midline, then you don't probably would need this extra 2 to 3 centimeter exposure. But if it is right in the midline, involving hair, or probably coming slightly over towards the other side of the hemisphere, then a very good idea is to expose the contralateral hemisphere as well. So, apart from the incisions, let's move. This was the second variation, and I know people who do this. I have never been very comfortable with this one. So if you just make one burr and the other burr holes are on the other side, ideally, to make a good craniotomy, if you're working in a very good, well-resourced setup, then, for example, if there is the lesion, then you're going to plan the craniotomy according to the neuronavigation. We usually don't have the neuronavigation. So what we do is we calculate the trajectory, the margins, etc., the topographic anatomy from the MRI, and then we end up marking everything manually, the motor cortex, the central sulcus, etc. This is the trapdoor incision that I just discussed, and the other incision is bicornal. Bicornal, if the lesion is even more posterior, the bicornal will not give you good exposure. But if it is anterior third, or just at the junction of anterior and middle third, then the bicornal incision will suffice. This is the craniotomy after the incision has been given, and the incision you can see here is a trapdoor incision. People also call it hinge flap. There are multiple names for this. I have also always liked to call this a trapdoor. So this is a trapdoor incision, and you can see the craniotomy, which is extending up to the superior sagittal sinus. And they have used the second technique that we were discussing. So let me mark here, if this is not clear. This is the superior sagittal sinus, which is completely exposed. And this cadaveric dissection does not show the contralateral exposure here. Ideally, you should extend your craniotomy to the other side as well. And then what you end up doing is, let me change the color. The dural flap is based on the superior sagittal sinus. Can somebody tell me the two important reasons we do this? Why do we raise the dural flap based on the superior sagittal sinus?
For tamponade effect, if there's a bleed.
Sorry,
Sorry.
Dr. Lalita, you were not clear.
For tamponade effect, if there's a bleed.
Yes, we want to protect the superior sagittal sinus. There is another reason. You would want to see the veins which are entering the superior sagittal sinus. If you are taking the dura over this side, apart from giving it a tamponade effect and protecting it, it's also called the sinus sandwich. It's going to come later on. So this is the sinus sandwich, but what it does is it also exposes the veins which are entering from the side, so that, you know, whatever decision we are making, that is going to be informed. Are we all clear, or am I going too fast?
Clear.
Okay, moving on. This is the sinus sandwich I was talking about. It's going to protect the sinus for us. And what we do is we flip the dura on the other side, but it also gives us very good exposure to the veins which are entering the sinus. I'm sure all of you would have experienced this, that for meningioma surgeries, there is extensive amount of bleeding, even when we are at the craniotomy stage. And before we even touch the dura, usually the dura is also heavily vascularized. So you need to do some bipolar coagulation before you even raise the dural flap. And when we are raising the dural flap, and this is not showing the lesion because this is only an illustration for the technique, but you have to be very careful when you're peeling this, because if the tumor is adherent to this, then there will be some vessels here as well, and it would bleed. So you need to do this very carefully, very gently, without much of a traction, and having this in the mind that dura would give some resistance if it is adherent to the lesion. This is showing the interhemispheric exposure. Assuming you would have to use your imagination from now. If there is a lesion here, let's draw this. If there is a lesion here, then the lesion is going to push this cortex away towards the lateral side. The sinus is going to be pushed towards this side. So what you would have to do is, you would have to create a plane very gently between the sinus and the tumor, using the cotton patties, using the suction in your non-dominant hand at very low suction power, and, you know, gently separating it, creating a plane here. Because on the other side, even if the lesion is not completely involving superior sagittal sinus, there will be a falcine component. So if the lesion is adherent to Fox, you would still have to be careful. because right under this one, I'm going to show you the picture. Once we open this, there will be the pericallosal artery, there will be the callosomarginal artery, and there might be feeders. So even with the falcine part, you will need to take better care of the lesion. Moving on. So this is an illustration, and this was an illustration for a falcine meningioma, not particularly superior sagittal sinus meningioma, but the principles stay the same. Can somebody mention the core principles of meningioma surgery? What were those? Anybody? They were easy.
Detress, devascularize, debulk, decorticate, and deliver, I think.
Yes. So we need to devascularize. We devascularize the dura, we devascularize the capsule, we identify the feeders if there are any. Usually the feeders come from the base or directly from the meningeal layer above. So we need to identify the feeders, devascularize them. After devascularization, what do? We debulk, open up the capsule, and we debulk the central core using accusa, using dissectors, using the monopolar, what is that called? The cutter, the round thing. So depending on how the consistency is, if it is fibrous, then it is not going to come out until unless you're going to use scissors or some sharp instrument. If it is softer in consistency, then it would not give you a hard time. After you have done the debulking and you have taken out the central core, the capsule will have a lot more space to collapse on its own, but usually there are adhesions. So afterwards, you're going to create, for example, they are doing this here, they're creating a plane between the lesion and between the cortex. You never do this if you have not centrally debulked it. Like they have not debulked it yet, and they are trying to create a space. If a lesion is giving you some natural plane, good enough. There will be very innocent looking lesions that they will give you this space. If they're not giving you this space, then do not force yourself in. Devascularize this portion, open up the capsule. Usually we do this in a cruciate manner. We open up the capsule, we debulk the core. Once the core is debulked, it goes like a deflated balloon. It behaves like a deflated balloon, the capsule, and it will give you some space here. So in that space, you have to very sneakily put the cotton patties and create a very gentle arachnoidal dissection using micro scissors, separate them and reach the base. Why did I mention the base? Because a lot of tumor feeders will be coming from the base. Now, what we do is, I have seen this happening once in OR. Somebody got really excited once they were done with the debulking and dissecting the arachnoid away. What they did was gently tug on the capsule, and there were feeders in the base, and it started bleeding very briskly. And that is not a situation you would want to end up in. So when you have reached the base, be very careful. Try identifying the feeders. I have mentioned this before. Usually, feeders end here like this. Whereas if it is not a feeder, if it is a hairpin bend, you will see the same vessel making a loop, a hairpin bend exiting. So one of the signs of the feeders is it will usually be in the base, either here where the dura is, and you will see some feeders, or from the base. Apart from that, once you have identified it and carefully, extracted it away, taking care of the falcine portion as well, now comes the sinus management. But let's look at the other images first before we move to the sinus management. So this image is from the Mefti, El Mefti, which is the book for meningioma. And you can see that they have developed a really beautiful plane between the surface of the brain and the lesion, and the cotinoids are very gently placed. This is what I was talking about. This image is from an anterior interhemispheric approach, but please remember that the anatomy remains the same, and the vicinity or the locality you're working in, it also remains the same. So your lesion is probably going to be slightly superior, but even if it has a brief component of Fox involvement here, then you can see that there is callosal artery, there is pericallosal artery, the other one is retracted because this is a cadaveric section. And you can also see the corpus callosum, whitish band. You can see the cingulate gyrus. You can see the anterior medial frontal artery, something. I have forgotten the complete name of this. But if a lesion is here or somewhere here, it's very easy for it to drive the feeding arteries from here. Let me change the color. Branches from here or branches from here end up supplying the lesion. So once you have reached the base, make sure that there are no feeders here, or there is, you are not tugging on pericallosal or the callosomarginal artery. Regarding Fox, if you can resect it, then resect it. You can take a small portion of Fox away. It's not going to be severely detrimental. Let's move to the sinus, which is a very heated discussion. It still remains highly debated. Please see. What you see here is the extraction of the intrasinusoidal tumor here. Right, this here. This is the intrasinusoidal segment of the lesion. What they have done is they have opened up the wall of the sinus, and placing the surgical pledgets, they have gently extracted it, and afterwards they have reconstructed it with a fascia temporalis patch. The other option is saphenous vein graft or a Gore-Tex patch. If you're using saphenous vein, then you need to be sure that the vein is maintained its the craniocaudal direction, because there are valves in it. So if you don't maintain the craniocaudal direction, then there can be thrombosis inside. Even with this, flap reconstruction, the recurrence rate is higher, and the failure rate of this graft is also very high. So if you're early in your career, I genuinely do not recommend doing this. Do not do this until unless you have some exposure of the neurovascular surgery. It looks easy on the illustration, but trust me, middle superior sagittal sinus is a very unforgiving part, and it will not forgive you. So if you're early in your career trajectory, stay away from it. You can always send these patients to the SRS afterwards. So these are all the steps that we have discussed. All these, with the images. Let's go through these steps very quickly. If you have any questions, let me know. You can stop me in between. I'm sure you all know this by this point. So it's really important how you're planning your surgery. Assess the MRI brain. You need to have a tumor size. You need to see its relation to all the eloquent cortex, even the edema, and the extent of the edema. And as a surgeon, you would be hugely benefited if your topographic anatomy is good. Apart from that, you would want the venogram or CTV for severe sagittal sinus patency, etc. DSA is gold standard, but DSA is not widely available in every setup. So if you get it, good enough. If you don't, or if you can't, then even a CT venography or an MR venography would suffice. Apart from that, neuronavigation is obviously, it's a pro if you have it, but if you don't have it, this is still possible. You need blood, you need a lot of blood. and you need copious steroids to manage the edema. The anesthetist also needs to be meticulous about, uh, the hyperventilation, the mannitol, all the other measures we take for reducing the ICP. Because if the brain is angry or if it is edematous, the resection is going to be very difficult. Position is supine, mainly for anterior middle third lesions. For the posterior third lesions, we can go lateral, we can go park bench, we can go 3/4 prone. We fix the head in a Mayfield clamp, and the same principles remain. We elevate the head above the heart and rotate the head slightly so that the lesion side is uppermost. Excessive neck rotation is a problem. Jugular compression is a problem. We know that this is going to lead to venous congestion and raised ICP. Incision we have thoroughly discussed, and I don't think there is any need to discuss it again. Craniotomy, I have shown you the variants. You can place burr holes on both sides of superior sagittal sinus, or you can place burr hole on only the contralateral side. And the dura needs to be separated carefully from the inner table. Apart from that, you need to expose the contralateral sinus margins as well. The ipsilateral is a done thing, but the contralateral sinus margin is also going to be exposed because you want some proximal control. The dural flap is based towards the sinus. We preserve the cortical draining veins, and we protect the cortex and veins with cotinoids. There was a topic, not exactly a topic, a subtopic that I wanted to keep in here. I will leave a PDF handout for that. How do you identify artery versus vein? As in, when we are coagulating, this is a question that is often asked in exams, in Viva, and it's something that you need to know on the surgical table as well. How would you identify this perioperatively? Can somebody answer?
Ma'am, using Doppler
Okay, apart from Doppler, what other options do you have?
can be by palpation,
What do you mean by palpation?
by finger palpation.
Okay, so what are you going to feel on the finger palpation?
I think there will be pulsatile pulsation of the artery.
Okay, and how will the vein would be?
I think it won't be pulsatile as much as the artery.
Okay, there are a few other things as well that you can do to ensure that what you're coagulating is actually a vein and not an artery. What are those? Okay, he was on point for the most part. When we are using a microscope, an artery is usually visible as a pulsatile structure. It's going to be pulsatile. The color is often bright red. It looks beautiful on a microscope, whereas vein would not be pulsatile until and unless it has been arterialized, which is not the case here. It would be a case if this was a hemangioblastoma or if this was an AVM, where the veins are arterialized and it's difficult to identify them just on the base of naked observation. But for cases like parasagittal meningiomas, you would be able to sort of identify them on the microscope. If you're not sure, there is a technique which is temporary. So you can temporarily block them with the help of a bipolar, not coagulating, only, hold the vessel between between your bipolar forceps. Just hold them gently, close the lumen, do not burn it. If you see some congestion, then this is most likely a vein. If you don't see any congestion, then there is artery. Also, once you know you are using the bipolar to get some tactile sensation, then the artery will be slightly more tensile, and you will be able to feel the pulsation of it, whereas veins will collapse easily. Apart from that, microdoppler is a really good option. You were right. And we do not use them in parasagittal meningiomas, but it's a technique worth knowing. Indocyanine angiography is an option. If somebody probes you more, you can say that indocyanine angiography would be an option, especially in the vascular causes. Here, I think microdoppler would suffice. I will leave a small differentiating table. Apart from that, if you end up, coagulating the cortical vein, then the venous infarct and the brain would get suddenly congested. So you would know that, okay, this was a vein, but you want to be very sure before you coagulate it, especially if it's a bigger vessel. So yes, coagulating these dural arterial feeders, we detach the dural base where it is safe, internally decompress the tumor using CUSA, using unipolar, whatever is working on that tumor consistency. Before the circumferential dissection, we reduce the tumor volume so that there is no traction on the cortex. Somebody that I have worked with during my own residency, what they did was they used to take a suture in the tumor capsule. And for example, this is the tumor capsule, and they would take a suture here and use this suture to retract the capsule instead of retracting the brain itself. So this capsule would be retracted, the suture would be manipulated, the thread would be pulled, this would be retracted, and there will be no retraction pressure on the cortex, which is our goal. Fixed retractors, they make the job easier, but they also increase the risk of morbidity postoperatively. We develop the arachnoid plane, we dissect circumferentially, we preserve pile vessels. We have discussed all of this. If there is involvement of any major vein or sinus, then we leave the tumor there. We also avoid coagulation or avulsion of veins which are entering the superior sagittal sinus. And subtotal resection is fine if this means that the patient will end up walking out on their own. When we talk about the management of sinus involvement, if it is anterior third, you're in the safer territory. You can coagulate it, you can resect it. There are two schools of thought there as well. There are schools of thought that say that patient can have frontal lobe syndrome postoperatively. There can be mild venous congestion and some problems like abulia, akinetic mutism, etc., etc. That's a relatively smaller school of thought. Apart from that, anterior third can be taken away without much consequences. Middle third is a very shaky area, and it's better to be safe than sorry. And posterior third is, I consider it, the posterior third is sinus involvement similar, because the occipital cortex is involved, and the patient can have visual symptoms postoperatively if you end up compromising it. So if it is middle or posterior third sinus, it's always better to preserve the sinus and send the patient for SRS. Yes, the other very important subtopic, air embolism, because you are opening up the sinus, or even if you did not want to open it, it was an inadvertent thing that just happened. And even if the venous lacunae got opened, so there will be a risk of air embolism, especially if the patient was in semi-sitting or the sitting position. How will you identify this? This is a very brief handout. I will leave the detail as a PDF on the WhatsApp group, inshallah, how to identify what measures to take and how would you manage them. So the end-tidal carbon dioxide, if there is a sudden decrease, that is the earliest marker usually. Patient will start desaturating. How do you confirm? Also, there will be hemodynamic destabilization, which will be very sudden. There is no new bleeding in the field, but the patient is now suddenly losing the pressures, losing the sats. You need to know that probably there is venous air embolism. How do you confirm? Precordial Doppler is one method which is usually available. The gold standard is this esophageal echocardiography. This is gold standard, but it is often not feasible. So what is more feasible is a precordial Doppler, and it is also easily available in a lot of setups. There it is. Then we have the false sign component. We have discussed it. We remove the involved fox and we protect the pericallosal arteries and the contralateral cortical veins because they are entering from the other side. And we will avoid the excessive contralateral dissection. How do we close? We close after achieving meticulous hemostasis. We want to be 100% sure. How do we know that? After we have done all the hemostasis, we irrigate the field continuously. What that irrigation with saline is going to do, it's going to close any residual small microbleeds, and it's also going to give us a very good view regarding whether there is any bleeding whatsoever. Another option is to ask the anesthetist to raise the blood pressure slightly, like by 10 mm mercury. That will also give you an idea if there is some chances of bleeding somewhere. So after you are 100% sure with hemostasis, perform watertight ureter closure. A graft can be placed, could be periosteal, could be fasciolata, could be artificial. Replace the bone flap, take up sutures, close the galea, etc. Postoperatively, you want to monitor for seizures, for venous infarction, for brain edema, for hemorrhage, and for motor deficit. And post-op MRI with contrast within 48 hours. If you can't get it within 48 hours, then the other option is after 6 weeks. Because in between, there will be changes that will probably, mimic some residual. So if you want a post-op MRI, get it within the first 48 hours. You will continue steroid for some time, then taper gradually, and continue anti-epileptics. Do we have any questions? It was a long session. Ignore this slide. This is not going to be continued. This was a wrap. Any feedback and questions are welcomed. Let me know if you have any questions.